It's a great pleasure to welcome everybody. Just admitting somebody else. This is our first webinar, and it's our first network meeting outside of the main ISCOS meeting. So it's a really special occasion, and it is being recorded. It's being recorded at the moment. We're hoping, if all technical things work well, that will be available to everybody who's registered through the ISCOS YouTube. So many innovations happening in relation into the Psychosocial Special Interest Group. And we've got over 62 people who have joined us. So a brief intro from me, and we will get the meeting underway. And thank you very much, everybody, for coming. I know it's tricky with time zones and things, but hopefully people will be able to join us who on the recording if they weren't able to join us live. So my name is Jane Duff. I'm chair of the Psychosocial SIG. Stan Ducharme, who's the former chair, is with us as well. And we want to welcome everybody, anybody who has an interest in psychosocial issues, not necessarily psychologists, not necessarily peer counsellors or psychiatrists, but anybody with an interest in psychosocial issues is welcome to the Psychosocial SIG. Really importantly, for the networking meeting, you don't have to be a member of ISCOS to stay for that. So I'm chair of the SIG. In my day-to-day role, I'm a clinical psychologist at the National Spinal Injury Centre, which is at Stoke Mandeville Hospital in the UK. And the webinar today involves Kim, Angie and myself presenting about appraisals of injustice after spinal cord injury, which came about as a conversation that we had and kind of interests of ours. Tyne and Van Diemen will then chair a moderated panel discussion for about 10 minutes, and we'll have a SIG networking meeting after that. So a couple of the kind of Zoom practicalities. We are recording at the moment. We'll also be taking some screenshots to publicise on our Twitter and LinkedIn profiles. And if you are on Twitter or LinkedIn, we would encourage you to follow us. We've only been on LinkedIn for a couple of months, about a month or two now. If for the webinar itself, if you post questions for the presenters in the chat whilst presenting, Tyne will then kind of collate those. If you mark them question, that'll help him. You're very welcome during the moderated panel to ask any questions. If you just want to raise your hand, Tyne will pick that up and come to you and unmute you for that question. The network meeting itself will have a gallery view because we want it to be as participative as possible, and raise a hand for that meeting, and I will be chairing that meeting, and I'll unmute you. And any technical issues, please mark the information for ISCOS Society Tech. I have a laptop here, so I'm ISCOS Society Tech for want of a better introduction. So I will try and address those in the chat. So I'm going to hand over to Tyne to introduce the meeting, and then kind of come back to you shortly. Thank you, Tyne.
Yeah, thank you, Jane, for organizing this beautiful event for tonight, at least for me tonight, for some of you this morning. I'm very happy to announce this first webinar, mid-year webinar, and it's more or less an experiment. So if you have any feedback, please contact us and help us to improve for next year. Very happy to introduce Jane Duff, Kimberly Munden, and Angie Philippeson. They will tell you more about appraisals of injustice, a very important issue for psychology and spinal cord injury. Jane, I will give you the floor.
Thank you, Tyne. So, as I mentioned earlier, this talk arose from a conversation that Kim and I had, and I'd heard her presentation about injustice appraisals, which she's going to share with you later today. And we thought it would be helpful to begin with an overview of appraisals, how they fit with stress reduction and psychology models. And for some years, stress has been recognised as about a balance, and stress occurring when there's an imbalance between perceived demand and perceived resources. And that led to Folkman and Lazarus developing a transactional stress model. And the key thing is that appraisal is about perception. And the model suggests there are 4 types, whether something is perceived to be a threat, a challenge, loss, or benign. And that coping is what we do to keep or restore the balance, to level up those scales. And appraisals are not a new idea, and perception is not a new idea, and was recognized in Greek philosophy. But it's interesting that it's still one that we're talking about and working on and trying to improve our knowledge on. So coping is what we do to either master, reduce, or tolerate demand. And Folkman developed and Lazarus developed what they called coping effectiveness training for people with HIV. And they used that to test the idea that stress is reduced when the perception of the appraisal fits the coping strategy, when the two knit together like a jigsaw. That's what leads to stress reduction. And actually, in terms of their research, they took saliva swabs from the inside of people's mouths and to develop the CET intervention, the coping effectiveness intervention. So they developed a model to operationalize the CET intervention, which suggests that using mainly problem-focused coping for situations that are changeable, and emotion-focused ones for situations that are unchangeable. In 2003, Paul Kennedy and I developed this model of spinal cord injury adjustment. It keeps the central appraisal coping fit of the Folkman and Lazarus model, but for spinal cord injury adds 2 crucial things: that if the stressor will be reduced if there's a belief about manageability. So that will be more likely to, so if that fit occurs, that manageability belief will be more likely to occur, which will lead to approach-focused coping and a range of positive psychosocial outcomes. If the fit doesn't occur, the model suggests that that spinal cord injuries, unmanageable beliefs can occur, which are more likely to lead to avoidance-focused coping and the risk of potential emotional impact. And crucially, the system then needs rebooting into that reappraisal process that Folkman and Lazarus suggest. This is a simplified model and one that we can use to map onto Paul Kennedy's research, both in terms of research that he did and the appraisals of disability, primary and secondary scale, that I'm going to talk about shortly. So Paul followed up people from his coping study at 21 years and found that the coping that people used at 12 weeks after injury, so those very early stages, predicted depression at 21 years, and also had associations with the coping strategy used and mortality. So really important to meet with people early on in their rehabilitation to understand how they're coping and adjusting. For the remaining sample at 21 years follow-up, Paul asked them to complete the appraisals of disability scale because he developed that since doing the original research. And he looked at people's appraisals at 21 years and the coping strategy they used and mood at 12 weeks after injury. So acceptance and positive reinterpretation as a coping strategy at 12 weeks after injury predicted positive and negative appraisals at 21 years. And depression at 12 weeks after injury predicted negative perception of disability and overwhelming disbelief at 21 years. So a little bit more about the appraisals of disability measure. Both the full scale and short form have the same 2-factor structure of catastrophic negativity and loss or determined resilience, and both have 3 subscales within each of the factors. In the full scale, the scores for each of the subscales are summed and interpreted into either a normal range, upper or lower normal range, and a high or low distress range. And the short form has a question from each domain and gives a total score with a cutoff of 22, recommending that the full scale be administered. It's a scale that's been designed and validated in spinal cord injury and used worldwide. And there's a link on the slides, and also going to put it in the chat with a copy of the full scale, the short form, and a summary of the psychometrics. And just to say, we're going to do a PDF of these slides and send them out to everybody. So you'll kind of get those links as part of that. Returning to think more broadly about where appraisal perception might come from and the relationship with our core beliefs and worldview. So in the model, it recognised those kind of factors, those pre-injury factors. So we know emotional history and vulnerability, environment, biological factors, and social support are key. And also that social and rehabilitation psychology is the central role of the person-environment interaction that's important. And that individual appraisals of personal circumstance, as well as the interaction with the social physical environment, can have profound consequences for coping and adjusting to disability. So thinking specifically about beliefs, and which links with the Injustice Experience questionnaire, it's often the beliefs that people hold about themselves and the world, such as certainty and predictability, and why good and bad things happen, that are key to the appraisals that the people then make in terms of that threat, challenge, loss, benign. And those beliefs, I think, are probably a reason why in the pandemic that mental health has worsened, because people's perception of control fundamentally has really been threatened in the course of the pandemic. So spinal cord injury can pose a threat to core positive beliefs, and also activate negative belief sets. And these core beliefs are influenced by the sense that we make of the world, perceptions of injustice, and just as often we're not aware of our cognitions, also people are often unaware of the appraisals that they make. So when you ask people, what did you think, they talk about what they did in a situation, because the appraisals are so implicit that we often don't recognize or realize whether that's a threat, challenge, loss, judgment that we're making. We go straight to what we're doing in terms of what we're coping. And that's where the fit bit can go a bit wrong. So pertinent in spinal cord injury are people's beliefs as well about disability, not just the world and the worldview that they hold, but previous experience of adversity, experience of disability, or the role models that they've had. And that can influence whether an injury is considered to be a threat or challenge. And this is a quote from a patient I saw many years ago. My life has been a series of 2 steps forward, 1 step back, and then forward again. And that was the approach that she took towards her understanding of spinal injury. So in terms of coping effectiveness training that I mentioned and stress reduction, the problem is, as humans, we've developed coping strategies, preferred strategies, things that we always have our go-to. And those, so for example, we might use problem-solving strategies for unchangeable situations. And that's where the CET bit from Footman and Lazarus came in to influence that kind of process. So some data from 241 people admitted to Stoke Mandeville between 2015 and 2020 in terms of the ADAPT short form. So that was, they completed that on admission and discharge. Scores, as you can see, were in the full range, and a third of the patients scored above the clinical threshold of at least 22. So the psychology service at Stoke Mandeville is referral based, and we're not resourced, unfortunately, to assess and treat all inpatients. But what it enables us to do is to look at those who received a psychological intervention and those that didn't. People who received an intervention are in orange, and they had demonstrated significantly more loss appraisals than those who did not receive an intervention. Appraisals were significantly correlated with mood. At that moment in time, we used the HADS. We now use the PHQ-9 or the GAD-7, but mood was correlated with appraisals. So that reinforces the importance of assessing mood and assessing appraisals, and screening for the management of psychological disorders after spinal cord injury. The intervention we provide at Stoke Mandeville is tiered by mental health psychological complexity. So the highest levels have current self-harm or historical risk of self-harm, and this was one group in the analysis. Inpatients who received a routine intervention were a second group, so those are people who would be recognised as having adjustment difficulties or difficulties with managing mood. A third group were a brief intervention group, and then there was a no treatment, no intervention group. So those with the highest complexity, so people who had significant risk, either historical or current, demonstrated significantly more loss appraisals than those who were not referred or stroke provided with psychological treatment. And the green box indicates a statistically significant difference. Looking at the domains for the group data is really interesting, and we've done this especially for this presentation. So we can see changes in overwhelming disbelief and fearful despondency, but interestingly, very little changes in terms of negative perceptions of disability. In terms of resilience, a reduction in personal agency by discharge, which is a concern, and a slight reduction in determined resolve, but interestingly, an increase in the domain of growth and resilience. This mixed picture isn't necessarily surprising because we know that adjustment continues after the first few years from transition from hospital to home. But my clinical impression is that overwhelming disbelief can be associated with symptoms of anxiety, fearful despondency associated with increased symptoms of depression, and either one of those coupled with negative perceptions of disability are a real flag for me about somebody maybe having adjustment difficulties. And I also wonder whether perception of injustice is related to the maintenance of negative perceptions of disability, and a potential future area for research. So one of the most frequently asked questions in the early days when I see people with spinal cord injury is, why has this happened to me? And I need to make sense and reconstruct reality, both in terms of global meaning and situational meaning. And if situational appraisals threaten the global meaning, that's when I think core assumptions and schema can be activated and threatened. So I've just, in the last couple of minutes, got a couple of brief case examples, one of which has been published with the link that's there. And this was somebody who, we did the short form of the ADAPTs. And as you can see, the loss appraisals change through the intervention. And the personal agency appraisals improve. And they're written up in the spinal cord case and series. This person we haven't yet written up and was presented at the ESPA conference recently. And it's a case study of using the full scale of the appraisal disability measure. He had very high loss appraisals of fearful despondency and negative perceptions of disability, and low determined resolve and growth and resilience. Mid-therapy, the resilience factors had improved, although personal agency had lowered slightly. At the end of therapy, resilience was maintained and personal agency had re-improved back to a higher level than previously. But most significantly, I think fearful despondency and negative perceptions of disability had improved. And the presentation I gave for ESPA was about how we worked on kind of influence of control, acceptance and commitment therapy strategies, and mindfulness, and different things to help improve that. Just a few clinical impressions in the last few moments. It's a real flag for me if somebody is over 22 on the short form of the ADAPTs. I use the full scale therapeutically. I use it to plan my intervention and plan collaboratively what I'm going to be working on with somebody. I usually share the results with them and talk about the domains. I'm concerned if anybody has any lost domain endorsed. I'm additionally concerned if that's associated also if there's a negative perceptions of disability endorsed in combination with either fearful despondency or overwhelming disbelief. And if there are no resilience domains endorsed, that's a kind of another an additional flag for me. I used the ADAPTS and the Injustice Experience Questionnaire, which Kim and Angie are going to come and talk about in a minute a bit more. I've reviewed so I use it in medical legal practice. I've reviewed the settled cases in relation to that over the last couple of years. And these were people 2 to 5 years post-injury. They did have a medical legal claim going on, which does impact. But people who were above 75th percentile on the IEQ in terms of both factors, I noticed they were also always in the high loss domains in terms of fearful despondency or negative perceptions of disability. They were strong on the resilience factors, but those didn't seem strong enough to be able to buffer the impact of loss perceptions. So thank you for your time, and I look forward to talking with you more in the panel. And I'm going to hand over to Kim. It gives me great pleasure to introduce Kimberly Mondon, who's going to present on the qualitative study of injustice appraisals after spinal cord injury. Thank you.
Thank you, Jane. It's a pleasure to be here today. As Jane mentioned, my name is Kimberly Mondon. I'm an assistant professor in the Department of Rehab Med at the University of Minnesota. And today I'll be talking about a qualitative study we did on perceptions of injustice or appraisals of injustice. We use those terms kind of interchangeably in the research after spinal cord injury. And this study was actually published in Rehabilitation Psychology in collaboration with Angie Philippus, who will be presenting next, Christina Dragonich, Bria McIntyre, and Susie Charlefew at Craig Hospital. So individual appraisals of injury or disability arise against the backdrop of deeply ingrained cultural orientations towards justice principles. And according to just world theory, individuals are socialized to view their world as consistent, predictable, and fair, a place where people generally get what they deserve. Next slide. So what happens when something happens to somebody that they feel they didn't deserve? And this is when appraisals or perceptions of injustice can arise. So perceived injustice is an appraisal comprising elements of the severity of loss due to an injury. And it's likely to arise when such assumptions are violated and accompanied by undeserved suffering and loss that interfere with valued goals, as may be the case after a physical injury or disability. Next slide. So perceived injustice is a psychological construct conceptualized as an appraisal process characterized by severity and irreparability of injury or disability related loss, externalized blame, and perceived unfairness. Perceived injustice is the belief that one's injury is undeserved and attributable to another's error or negligence. So it's made up of these two constructs, severity and irreparability of loss, and blame and unfairness. Next slide. In some of my previous research, we found that higher injustice appraisals contribute to worse physical and psychological outcomes after spinal cord injury, including pain intensity, perceived disability, depressive symptoms, less likelihood of return to work after injury, and post-traumatic stress symptoms. Next slide, thank you. So findings from our previous cross-sectional quantitative work suggest that perceived injustice is an important factor for negative outcomes following spinal cord injury. As you can see in this table, we have found several predictors of injustice appraisals during inpatient rehabilitation for spinal cord injury. So greater time since injury, higher expected disability, greater pain intensity, higher state anger, and increased post-traumatic stress symptoms in this study were all significant predictors of increased appraisals of injustice during inpatient rehabilitation for spinal cord injury. Despite these findings, there are currently no interventions that specifically target perceived injustice. And we thought that before developing a targeted injustice intervention, it was important to develop a rich understanding of the sources and contributing factors of perceived injustice. Next slide. So the purpose of this study that I'll be presenting on was to qualitatively explore how individuals with spinal cord injury conceptualize appraisals of injustice to identify common sources and contributing factors of injustice appraisals. So our research questions were, how do individuals with SCI conceptualize injustice? And what are the common sources of perceived injustice? and what factors contribute to perceived injustice. Next slide. As I mentioned, this was a qualitative study. So we had 15 individuals in the United States who participated in a semi-structured interview. And in this interview, we asked them to give a brief description of how they were injured. We asked them to complete the injustice experience questionnaire. And then we asked them to answer questions based on their responses to 4 of the items on the IEQ. Next slide. I think you might need to click again, Jane. There we go. So this is the IEQ that Jane and I have been talking about, and Angie will be discussing in more detail after I present. So it consists, again, of items representing the severity and irreparability of loss and blame and unfairness. So these are the items related to severity and irreparability of loss. So one of those items, for example, is most people don't understand how severe my condition is. Next slide. And these are the items related to blame and unfairness. For example, I am suffering because of someone else's negligence. And that's how the scale is broken up. You can look at the total score, and you can look at the subscores for these factors as well. Next slide. So as I mentioned, a subset of 4 items from the IEQ were used as the basis of the qualitative injury. So for severity and irreparability of loss, we use the following questions. Most people don't understand how severe my condition is, and I just want to have my life back. For blame and unfairness, we used 2 items. I am suffering because of someone else's negligence, and I feel as if I have been robbed of something very precious. So what we did is we said, okay, you answered this IEQ, and on this item, say, most people don't understand how severe my condition is. You rated that very highly. Can you please tell us what was going through your mind? For blame and unfairness, we would dig a little further, like, so what are some of the sources of blame and unfairness? Where do you feel that this injustice is coming from? Next slide, please. Then we conducted our qualitative data analysis, which involved coding and categorizing the data into themes and sub-themes using open, axial, and selective coding. And we conducted this using in vivo software. Transcripts were coded by 3 research investigators, myself, Angie, and Dr. Susie Charlefew. And after coding each transcript, each of us, so all 3 of us, would meet to review the themes identified, and we would discuss any disagreements that we had in coding until we came to consensus. Next slide. This shows the demographic information of the individuals who were enrolled in our study. So the mean age was 47 years old. We had more males than females. Education was about the same with college and no college. The majority of our sample was white. And as far as employment, it was pretty evenly distributed. Next slide. The average time since injury was 18 months. So these people were fairly early on in their injury. It was pretty evenly distributed across different etiologies of injury. So fall, motor vehicle, collision, and other. There were more cervical injuries than thoracic, and more incomplete injuries than complete injuries. Thank you. So those who were male, white, and unemployed tended to report higher appraisals of injustice. So that was what we defined as an IEQ greater than 19. Next slide. And those with cervical and motor incomplete injuries also reported higher appraisals of injustice. So a score greater than 19 on the IEQ. Next slide. So this slide shows how people responded to the 4 IEQ questions that we really focused on in the qualitative interviews. So starting on the left-hand side of the slide, the 2 questions related to the severity and irreparability of loss. And the majority of people endorsed the item, most people don't understand how severe my condition is, and I just want to have my life back. With regard to blame and unfairness on the right-hand side of the slide, the majority of our participants did not respond to suffering due to someone else's negligence. And finally, furthest on the right, the sample was pretty evenly split on, I feel as if I have been robbed of something very precious. Next slide. So these are when we did our qualitative analyses. Oh, thanks, Jane. When we did our qualitative analyses, these are the themes that arise in those two constructs. So for severity and irreparability of loss, the themes that emerged out of the data were life with disability, lack of understanding by others, and surprisingly, a focus on the positive. And then in terms of blame and unfairness, the themes that emerged out of the data were fate or circumstance and internalized blame, and finally, also stigmatization. Next slide. So I'm going to go through some of the qualitative results, which is going to involve me reading the quotes from some of our participants. So the theme of life with disability emerged specifically when individuals responded to the item regarding the desire to have one's previous life back. This theme included sub-themes of coping with physical impairment, loss of ability to engage in hobbies or recreation, bowel and bladder issues, inability to work, transportation, and pain. For instance, one participant stated, if I could go back and change anything, I'd go back and change that day, just because of what all has gone on since then. I mean, I had to sell a business. I've gone from being a fully capable person and doing anything and everything I needed to do to having to have help for virtually everything. So participants with high perceived injustice reference life with disability more often than those with low perceived injustice. So the next theme, lack of understanding by others, this emerged as a theme in reference to the item regarding the severity of one's condition and was equally noted by those with high and low perceived injustice. And one participant stated, so really it's not ignorance or stupidity, it's just a lack of knowledge about people that have spinal cord injuries or those in a wheelchair, that we don't choose the wheelchair, it kind of chooses us. So yeah, a lot of people have actually come up to me and said, I had no idea. So individuals reported a variety of disability conditions that were commonly misunderstood, from those specifically related to their injury to those related to disability in general. Next slide. 11 participants in our sample discussed the positive aspects of life with disability, and those with low perceived injustice referenced this theme more often than those with high perceived injustice. So an example of something a participant said when talking about focusing on the positive was, sometimes I miss my old life, but then I realize, well, my life could be worse. I could actually be dead. So it's not as bad. It's like a sometimes thing. Sometimes I miss my old life, but then I'm happy I'm alive and I get to watch my son grow up. So those were all the primary themes related to severity and irreparability of loss. And next, I'll discuss the themes related to blame and unfairness. So this is the theme of fate and circumstance. And when individuals did not ascribe blame to a particular person or event, they attributed their injury to something intangible, something like happenstance or coincidence. So for example, one participant said, I don't feel like it was anybody's fault. If it was anybody's fault, it was my own. But I don't even look at it that way because it was just kind of a freak occurrence. Even if I had hit somebody head on and went over the handlebars, I could have landed a million different ways. I could have just landed on my wrist. I could have broken my wrist or fractured my ankle or something totally innocuous compared to what actually happened. And what we found was that individuals with high perceived injustice actually reference fate or circumstance more often than those with low perceived injustice, which was actually surprising to us. We figured those with high perceived injustice would be more likely to blame a specific person or event. Next slide. We also came up with this, we didn't come up with this theme. The data told us there was this theme of internalized blame. So blaming oneself was referenced by those with both high and low perceived injustice, and is illustrated with the following quote here. Well, it was my fault. I wasn't wearing a seatbelt, so I don't really have anybody to blame except for myself. It would be different if I got hit by a drunk driver or something like that, but you know, it wasn't anybody else's negligence. It was my own, so there's nobody to blame but me. Next slide. And then finally, this theme of stigmatization became apparent in the data. So when discussing the blame and unfairness items, the concept of stigmatization really emerged and became pretty salient to us when we were coding the data. Individuals described their experiences of stigmatization by noticing and noting the looks they received from others. And this is really exemplified by the following quote. There's a lot of people that will look at you and say hi and stop and talk to you. And then there's a lot of people that will look away and avoid around you because they give you that feeling like, oh, I can't look, it might be contagious. And this was a bit of a surprising theme to us. We weren't expecting stigma to come up in the data. Next slide. So this chart on this slide here represents the percentage of people who identified each of these three sources of injustice, so society, family, and friends. So 80% of respondents mentioned society as a source of perceived injustice, and that really relates again to that stigmatization. People talked, I can't emphasize enough how much people talked about the looks they got from other people. 50% surprisingly mentioned family was a source of perceived injustice. Surprisingly, or maybe not surprisingly, I'm not sure. And then 20% mentioned that their friends were their sources of injustice. Their interactions with their friends led to a source of injustice. So for example, I remember one participant had talked about feeling ostracized from their friends because they weren't really considering needing to go to accessible venues when they were going out with their friends, or they would invite them over to their house, but not realize all of the obstacles in the environment and not being able to get in their friends' houses. And that was what led to a sense of perceived injustice. Next slide. So in summary, participants identified three sources of injustice: family, friends, peers, and society in general. And the lack of understanding was the most common theme that arose in the data. In response to the blame and unfairness items, participants spoke about who and what was responsible for their injury, and these sources fell into two categories: fate or circumstance, and externalized blame. And despite the emphasis on externalized blame in the conceptualization and the literature on perceived injustice, it did not emerge as a salient theme in our data. However, our sample did only include 4 people with injuries as being caused by the fault of another. So our sample may have been biased in that way. Next slide. So appraisals are associated with psychological distress and coping following spinal cord injury, as Jane talked about, and may be more amenable to change than dispositional coping strategies. Next slide. So I'm a rehabilitation psychologist by training. And so the way I conceptualize this is within some of Beatrice Wright's work. So Beatrice Wright conceptualized individual response to disability using a framework that distinguished coping versus succumbing. And succumbing is characterized by a predominant focus on negative aspects of a disabling event or condition and its consequences. So these are losses linked to the disability. Losses linked to the disability dominate an individual's attention. So they're focused on what cannot be done anymore in place of what can be done or learned or relearned. And people who adopt a succumbing framework are pulled under by the negative force of disability and its consequences, framing the disability as a tragedy and seeing themselves as victims. So as you move towards the coping end of the framework, the coping shifts focus to value and finding meaning in one's skills and abilities. So we believe the elevated injustice appraisals or perseveration on themes of loss, blame, and unfairness may pull individuals towards the succumbing end of Beatrice Wright's continuum and represent an important risk factor for negative rehabilitation outcomes. So, oh, sorry, Jane. Thank you. So again, thinking to the rehabilitation psychology literature, when I'm doing my injustice work, I often think about the need to bolster disability identity. And that says identify, it should say identity, I apologize. And I think this when I think about the stigmatization or life with disability, this is when I start thinking about some of the work in disability identity. So I think fostering affirmation of disability identity may be an approach to reduce appraisals of injustice. And disability identity and disability self-efficacy have been found to influence greater satisfaction of life among individuals with congenital and acquired mobility disabilities. And this could be accomplished through support groups and mentors with disabilities who can share adaptation strategies and serve as role models for people at various stages of disability adjustments. And with that, I will turn it over to Angie.
Thank you, Kim. All right. I'm Angie Philippus. I'm a research project specialist at the University of Minnesota in the United States with Kim. Kim's my mentor. I'm also a PhD student in a clinical science program, and I have a particular interest in psychosocial outcomes after traumatic injury. So my part of the talk here is a little more data heavy, but I wanted to talk a little bit more about the IEQ, the Injustice Experience Questionnaire, in more detail today. So this study that I'm going to present, we have published, and it is in spinal cord. And this was in collaboration with Kim and others that you can see listed there. Oh, there we go. We're going too fast. Try that again. All right, so here, Sullivan and colleagues, as Kim mentioned, were interested in this appraisal process, specifically as it related to individuals with musculoskeletal pain. And with their interest, they ended up developing this Injustice Experience Questionnaire, or the IEQ, as a way to assess injustice appraisals in this population. And they developed this in collaboration with clinicians who treat individuals with musculoskeletal injuries, as well as partnering with psychologists who provide interventions for those people. And they came up with these 12 items by using actual expressions from their clients. And then in 2008, Sullivan and team conducted a validation study to validate this measure in that musculoskeletal pain population. And they did so using principal components analysis. And in that analysis, their results revealed a 2-component solution, and those represent those 2 IEQ subscales that Kim spoke about. So the first one is the blame and unfairness, and it comprises these 6 items. The first is I'm suffering because of someone else's negligence. It all seems so unfair. Nothing will ever make up for all that I've gone through. I feel as if I've been robbed of something very precious. I am troubled by fears that I may never achieve my dreams, and I can't believe this has happened to me. And then this is the items that represent that severity and irreparability of loss. So these items are, most people don't understand how severe my condition is. My life will never be the same. No one should have to live this way. I just want to have my life back. I feel that this has affected me in a permanent way, and I worry that my condition is not being taken seriously. So all 12 items can be summed for an overall total IEQ score, or you can sum each of those subscale items separately to compute the corresponding subscale score. Higher scores on the IEQ are indicative of greater appraisals of injustice. After the initial validation study in that musculoskeletal pain population, the IEQ has since been validated in additional populations. So that includes fibromyalgia, whiplash, traumatic brain injury, musculoskeletal disorders, and once in a mixed trauma sample. But it has not yet been validated in a sample of individuals with spinal cord injury. Well, it hadn't up until the point we did. So given that injustice appraisals appear to be an important risk factor for poor outcomes, as Kim has described, among those with spinal cord injuries, we found it necessary to validate the IEQ for use in this particular population. Okay, so to do this, we conducted the validation study with the purpose of one, to verify the factor structure of the IEQ using a sample of individuals with spinal cord injury, and two, to assess the scale reliability and construct validity using the same population. Here for this study, we hypothesized our results would confirm that two-factor model that was reported in the original validation study, and then also in subsequent studies. However, if our initial results did not support that two-factor model, we planned on conducting an exploratory factor analysis to determine which structure does fit our data the best. We expected that the IEQ would demonstrate both good convergent and convergent validity, such that the IEQ would be positively associated with measures of perceived disability, depression symptoms, stigma, pain catastrophizing, pain severity, and a fear of movement related to pain. And we also hypothesized that the IEQ would be negatively associated with measures of self-efficacy and life satisfaction. So to address this, we conducted a retrospective analysis of data from 341 adults with spinal cord injury. And a little about the sample is the average age was about 50 years old. They were about 7.5 years post-injury and mostly male. About half of the sample reported living with paraplegia, and slightly less than half were married, employed, and used a manual wheelchair. Okay, so for the first objective, we started with a series of confirmatory factor analyses, and we did so using weighted least squares estimators and orthogonal rotations where the assumptions of normality did not apply. So CFA, or confirmatory factor analysis, was first conducted to evaluate that two-factor model that was determined by Sullivan and colleagues, and we've already discussed that. So this model is pictured here on this slide. And then we also went on to evaluate the IEQ total score in each subscale as a single factor model. And here I've presented the global fit statistics here. And just to briefly summarize, the quick 1-2 punches is none of the models met the recommended thresholds on these global statistics, but the blame and unfairness subscale did come close. All right, so since the CFA did not pan out as we had hoped, the two-factor with the two-factor structure, we moved on to the exploratory factor analysis to see what our data shows us, how many factors is appropriate. So we started with the scree plot, and it indicated that a 4-factor solution best fit our data. However, 4 solutions were ultimately evaluated for comparisons. So we evaluated a 1-factor solution, 2-factor, 3-factor, and a 4-factor solution. And again, here are these global fit statistics with each of those EFAs. And in summary, the 3 and the 2-factor models look the best, but the RMSE, or the root mean square error of approximation, doesn't meet the threshold of acceptability that we generally want to see. Nonetheless, here are those path diagrams for the 3 and the 2-factor structures. So each model demonstrated strong factor loadings, which are the teeny tiny numbers. They're the values between each factor and then each IEQ item. And then the alpha of each factor is presented in red. And this is the measure of internal consistency of each of those factors. Something to note, we generally look for values that are greater than 0.70. So you can see that not all of the factors met that threshold. Right. Okay, so far I've shown you that the global fit statistics aren't pointing us towards a perfect model here, but importantly, when conducting factor analyses, you also need to consider what makes conceptual sense. So to dig into these data a bit more, we took a closer look at each of the models to see if we could make sense of how some of these items are grouping together. So for example, here I'm showing you factor 3 of that 3-factor structure. So items 3 and 8 are grouped together. So the question then is, do these items together represent a cohesive theme? So for IEQ item 3, which is I am suffering because of someone else's negligence, it clearly represents an expression of external blame. Whereas the IEQ item 8 is I worry my condition is not being taken seriously. It appears to represent feelings that others lack an understanding of their condition. So kind of taking these two things together, we were unable to identify a meaningful underlying theme for this factor. So we wouldn't recommend this 3-factor model as a suitable solution. So we continued this process of inspecting the data and ultimately found that a 2-factor solution, which was very similar to Sullivan's 2-factor solution, made the most theoretical sense. However, the reliability of one of those 2 factors fell just below that 0.70 cutoff. So as a summary of this first objective, the results of the CFA and the EFA indicate that the IEQ measure could benefit from some refinement in this population. It's important to keep in mind that these IEQ items were originally developed in a pain population. So some of the items may carry different meaning when applied in the context of spinal cord injury. So for example, IEQ item number 4 states, no one should have to live this way, which implies that living with a disability is negative. So part of the refinement process may be to examine each of the IEQ items and its meaning as it relates to injustice among those with spinal cord injury. So it's possible that by adding, removing, or rewording items, we may see improved model fit. Okay, so let's move on to the second objective of the study, and that is to assess the scale reliability and construct validity. So scale reliability tells us the extent to which responses are consistent across a measure and its subscales. So this is measured by the Cronbach alpha. And again, we shoot for greater than 0.80 to demonstrate strong reliability, but greater than 0.70 is also acceptable. In this table, I've presented the alphas for the IEQ total and for each subscale separately, and you can see that all 3 met acceptability. Next, we assessed construct validity, or the extent to which our measure behaves the way we would expect it to with related or unrelated measures. This table presents correlations between the IEQ and the measures that we hypothesized would be related. So indeed, the IEQ was positively related to stigma, perceived disability, depression symptoms, pain catastrophizing, and pain. The IEQ then was negatively related to self-efficacy and life satisfaction. Contrary to what we thought, kinesiophobia was negatively related to the IEQ. However, the magnitude of that relationship was negligible. So I also want to point out the small sample size for at least 3 of the measures. I think the last 3 presented there. So these associations should be interpreted with caution. All in all, we think the IEQ behaves in a way that is consistent with what we would expect. All right, so if we put this all together, what does it mean? In this preliminary validation study of the IEQ in a population of individuals with spinal cord injury, the 2-factor structure, as described by Sullivan, was not confirmed. However, we did demonstrate moderate to strong internal consistency and construct validity. And it just shows us there's a need for additional research to refine the IEQ for future use in this population. And in doing so, this is kind of the next step that I hope to maybe do for my dissertation, but we want to engage individuals with lived experience that assist us with the development of a modified version of the IEQ. Thank you.
Thank you, Angie and Jane and Kimberly. Is there anyone who would like to ask a question? If you please raise your hand, then I can spotlight you and you can unmute yourself. Is there no question at all? Was it that clear, or are you all afraid to ask? No one?
Time.
Yes.
Please, may I ask a question?
Yes, you may.
Thank you. Kim, I was really interested in what you said about people having a heightened awareness of perceptions of others. And for me, it made me think of people I've seen with a lot of anxiety, and whether that you'd also notice perhaps a relationship with that, or kind of hypervigilance. I was wondering about the kind of people seeking a confirmation of threat appraisal in that kind of perception of others.
That's interesting. I hadn't thought about it that way. And I've never included the GAD-7 or an anxiety measure in my quantitative research, but we were recently funded by the DoD to do a longitudinal study of injustice appraisals. And so we are including the GAD-7 in that. So it will be interesting to see how it's associated with general anxiety symptoms, but we do know that it's related with post-traumatic stress symptoms. So you make a good point about the, maybe the hypervigilance and being overly aware of what's going on in one's environment. Looks like we do have a few questions in the chat, and yeah.
I see that Catherine has a question.
Sorry, we've got quite a bit of background noise here with children, but I was just basically wondering, to what extent do you think the factor structure inconsistency in the IEQ then leaves it a little bit questionable, really, in terms of its utility as a measure for SCI research?
Yeah, that's a great question, Catherine. Thank you. It's one that we've obviously thought about as well. This is a preliminary validation study. It wasn't a large enough sample to go back and be able to validate our validation study. So I would say that we did identify a two-factor structure that was very similar to Sullivan's that we think could potentially be used in the future. Right now, I think the way that we are looking at it is using it as a single factor structure, using the overall IEQ score, as opposed to breaking it out into subscales. But I do think that there is some work that needs to be done with individuals with spinal cord injury, helping us to kind of refine this and see if there's a way that we can improve it. But this one validation study, I wouldn't say is the end all be all, throw away all the research thus far. But I think it does give us a pause to think about how we want to use it moving forward. And again, I think our recommendation is probably sticking with the overall score. Is there anything you want to add, Kim?
No, I will say that was our concern going into that study, is like, what if we find that this isn't valid? Did we just unvalidate all of our work? But felt that it was an important question to ask regardless. And to Angie's point, I think the takeaway is to use the total score and not the sub scores.
And
thanks.
Oh, I'm sorry. One more thing to add to that too is, very important in validation studies is not taking the statistical numbers and, using that as your only evidence of a good or a bad structure. I mean, the thresholds are argued constantly and they change over time for some of those global fit statistics too. So it really does take a lot of thinking about, like, does this make conceptual sense, and it, looking at the data like that as well.
Thank you.
I do see that Les has his hand raised.
Yeah, Lester, please, can you unmute yourself and ask your question?
Sure. First of all, I want to thank ISCUS and the presenters. Convening people of like minds is always enjoyable, and so very much appreciate. 2 points. One, I was struck by the perceived social injustice relative to family. And one of the things that it really brings to the foreground for me regards the inclusion of family in the therapeutic process, in the rehab process. Was wondering your thoughts about that to potentially reduce the perceived injustice therein. It also reminded me of a book that was written in the early 90s, I believe 1992, Ronnie Janoff-Bullman, who was then at the University of Massachusetts in the US. And the book was called Shattered Assumptions. And it was, as a social psychologist, it was the phenomenological view of trauma and how people's world is shattered secondary to such. And it provided some very unique kind of perspectives relative to psychotherapeutic interventions. And I'm just wondering if that's known to the presenters, and I'd be interested in their comments about the family issue as well. Thank you again, very much appreciate.
Thanks, Leslie. It's great to see you.
It's good to see you, dear.
Yeah, the fact that people brought up family a lot was surprising to us as well. I will say, and Angie, correct me if I'm wrong, I believe it was a lot of people with incomplete injuries. And it was that struggle of like family expecting them to be able to function at a level that they couldn't because they didn't look like they were maybe as disabled as they were. And so I remember one participant talking about, his wife getting upset with him because he didn't carry the grocery bags. But he couldn't carry the grocery bags because they were too heavy. And so I believe it was a lot of people with incomplete injuries and struggling with, like, I don't look like I'm disabled, but I do have these limitations in my functions, and my family doesn't understand that.
And I know of literature way back when that talked about incomplete injuries having the most challenging experience because they couldn't live comfortably in the disability world or the AB world.
And that comes back to me again, to disability identity, to your point, exactly that. Yep. Where do I identify, And to your second point, oh, go ahead, Jane.
Oh, no, go Kim, I'll come in a sec.
Go for it.
No, sorry, I was going to say, Lester, the Janoff-Bullman work was something that influenced Paul and myself in terms of the model that I presented. Yes. Because my recollection, we wrote that chapter in 2003, and the Janoff-Bullman work is referenced in that. From my recollection, I think he talked about a pendulum and people swinging backwards and forwards and picking up from old identity, moving forward to a kind of a newer position, that position being an uncomfortable one, and that oscillation process happening as people adjusted to injury. And that's something that makes clinical sense to me, because that new position can be very overwhelming for somebody, and it is that kind of identity sense making elements that kind of influence my clinical work in terms of having that lady that I was the case study, the two Venn diagrams of her. She very much identified her old sense of self as being very feisty and matriarchal, and then her new one as somebody who's very passive and dependent. And trying to bring the two together in terms of her new identity, but recognizing some of the losses that she might have in relation to her older identity that she's not able to fulfill now. So the work is very pivotal. Yeah.
We do have another question from Charlotte. Please, Charlotte, can you unmute yourself and ask your question?
Hi, sorry, I have construction happening at my house, so I just typed it. But I work in Canada, and we don't actually have a neuropsychologist anymore. Their position hasn't been able to be filled, and so I'm assuming they are the people who would have done these scales. But I do have a rehabilitation center. So I work in a neuro ICU, so we kind of stabilize them and then send them to this rehabilitation center. So I'm just wondering whether or not these scales should be done in the acute phase and then repeated kind of when they're at the rehabilitation center, because that's the best way you get a trajectory on what their coping is and how they're actually healing, or whether or not you would just wait until they're in like the more chronic stage, the recovery stage.
Jane, do you want to touch on that, or? Oh,
I'm
you're
sorry?
muted.
I'm happy to, thank you. Can I just clarify, Charlotte, when you talk, because I think it varies from country to country in terms of what's acute and what's chronic and rehabilitated. So acute would be kind of how many weeks post-injury?
It really depends, because sometimes we have the patients who they're waiting to go to the rehabilitation center, and they still have other patients taking up the beds. So I used to work on the rehab floor also. So they stay in the neuro ICU until they're medically stable. Then they kind of go to the floor, start their rehab process until they can get a bed at the rehabilitation center. So I was thinking more kind of like when they're initially in the neuro ICU, which is typically like 1 to 2 weeks, I would say.
I think also being on the ISCOS psychosocial dataset group, we are kind of making recommendations in relation to the GAD, the anxiety measure, and the PHQ in terms of the depression measure. I'm trying to remember, Kim, I think there's some concern around that first 1 or 2 weeks in terms of people being kind of stabilized, but certainly the 2 weeks onwards time frame being maybe to do the measures of mood. Certainly in terms of appraisals, we in terms of the UK recommendations, we say to do a PHQ or a GAD from the second week of injury onwards, ideally in the window kind of 2 to 4 weeks. And then when people move into the rehabilitation phase, we would repeat the PHQ and the GAD, and then we'd use the ADAPS measure. But that's not I'm not aware of work that's been done in that very early phase with the ADAPS measure. But I would certainly recommend it as follow-up, and I'd recommend it as kind of follow-up reviews, for the first couple of years post-injury. Kim?
Yeah, I would. Sorry, I'm losing my voice. I would agree with what you stated, Jane. And I know of some injury in the U.S. or some studies in the U.S. Conducted by Anne-Marie Warren and colleagues, Dina Trost, where they use the IEQ actually in the ICU for any traumatic injury. So I know it has been used pretty early on, and also was associated with, I think, depression later on and some other negative outcomes. But in spinal cord injury specifically, I haven't seen it being used that early on. I've typically administered it in the rehab setting and have found it useful clinically there. Similar to what Jane was saying about the ADAPTs, looking sort of for the red flags and how to tailor what it is I'm going to work on with the patient.
Okay, that makes sense. Thank you.
But I would say you don't need a neuropsychologist to administer it.
And yeah, and also the ADAPTS is administered by any member of the MDT, not just a psychologist. OTs, physios, everybody administers the appraisals measure because that's part of our admission measure to Stoke Mandeville. And also the ISGOS dataset recommendation is for the PHQ to the short form or the GAD to short form to be administered by anybody, and then kind of an escalation up to perhaps a psychologist doing the long form or a clinical interview if needed.
Okay, all right, good to know, thanks.
All right.
And also, actually, just one more thing, Charlotte, I think if you're wanting to demonstrate need and evidence need for a neuropsychologist or a psychologist, collecting that data, MDT people administering those measures and collecting the data around need will make a really strong case around where that need exists and how a psychologist could intervene.
Yeah, definitely. Yeah, no, that's a good point.
All right, thank you all. Especially thanks to Jane, Angie, and Kimberly for the brilliant presentation. We have to close this part of the meeting because there's also a SIG meeting, if I'm correct. So I give you back the floor, Jane.